So I am Dr. Anuradha. I am the Medical Director of New Delhi Healthcare Academy, and I welcome you all on behalf of our complete team members. And today here we are together to begin with a new batch for the students who are enrolled with us in non-invasive clinical cardiology course and echocardiography course. As you know, echocardiography is part and parcel of clinical cardiology, and this investigation carries a lot of meaning for all of us who are doing a lot of clinical work where this is used as a main diagnostic tool. So we have Dr. Shaukat with us, who's into teaching of this course for us for many, many years. And he will introduce himself, that for how long he was working with Max Hospital Saket, and he's been into echocardiography and clinical cardiology course teaching as a main faculty since 2012. So our academy is in association with many Indian as well as foreign universities, wherein we are providing various diploma and certificate courses in healthcare courses like diabetology, cosmetology, ultrasonography, echocardiography, clinical cardiology, geriatric medicine, family medicine, and many more. And now we're going to also begin with some fellowship courses with the universities. If you wish to have some more information regarding any of these courses, you are most welcome to get connected with our counselors. And today we are beginning with a new batch for the students who are enrolled with us in clinical cardiology and echocardiography. And now I hand over the stage to Dr. Shaukat, and he'll begin with his first class. This echocardiography course is going to continue for about 30 to 35 hours, wherein we're going to cover the complete syllabus, and that syllabus will be soon shared with you with the course dates also. There is very little variation in case of any like emergency with any of our faculty members, but we are going to stick to that dates, and hope you enjoy this course. And I'll advise everyone to please be interactive and ask as many questions as possible so that this class becomes more interesting for all of us. And remember, this is not learning for only you, it's also learning for us, because at the same time, we are also learning from you all. So now I'll tell Dr. Shaukat to begin with his class and also give.
Hello, everyone. This is Dr. Shaukat. I'm working as a consultant in non-invasive cardiology in Max Hospital Saket from last 4 years now. 6 publications in Journal of Indian Academy of Echocardiography and 2 international publications. And I have written chapters in books. In latest one is the textbook of cardiology. And my chapter there is on hypertrophic echocardiography, recent advances in the navigation of echocardiography and hypertrophic cardiomyopathy. So coming to the scores, let's accept this, that echocardiography in itself echocardiography is just to assist the clinical diagnosis. I don't think it is a specialty in itself. Knowing the clinical picture of the patient, the history of the patient, it assists us like other investigations do, especially in cardiac patients. I hope I'll do every bit to make you understand the basics of it, as I've been doing from last few years over here. And let's make it interactive. Any questions, any doubts, you can ask me. So today's topic, what we have chosen is the basics of echocardiography. Basics of echocardiography, various modes of echocardiography, a little bit of physics about it, how it works, and the knobology of it. The knobs, various knobs in echocardiography machine.
Okay. So everyone is already unmuted. You just have to share your and you go with the class. If you need anything, just let me know.
Okay, sure. So let's begin with the introduction part. basic modes and waves of echocardiography. Sultan,
you have to just click over here once. No, it's okay. You have to
click.
No.
Okay. You have to be
little bit loud. So.
Okay. बोल रहे हैं ये लोग बोल रहे थे अच्छा okay. So let's begin with the introduction of basic echocardiography, basic modes and waves. So Bat Chungadir was the best ultrasonographer known to mankind, who, being blind, used ultrasound waves to navigate its path. Let me tell you, it is Igne Adler who is credited with being the father of echocardiography, and Feigenbaum. Various sources say Feigenbaum, whose book is widely in circulation, and that's one of the best books available on echocardiography. Some sources credit him with being the father of echocardiography. So Bat is blind, but by making use of the ultrasound, it navigates its path comfortably. So what does echo actually mean? It is basically, it acts on the same principle as the ultrasound. So it is ultrasonography of the heart and great vessels, and it is a diagnostic study that reveals information about cardiac structures and function of the heart and various hemodynamics of the heart. So whenever we will be commenting on echo, let's assume we have to know the history of the patient, physical examination of the patient, past history of the patient, and then we'll concentrate on echocardiography, which will help us in arriving at a diagnosis. We don't have to view echo, we don't have to see echo in isolation. It has to be according to the patient's condition, so that it helps us at arriving at a diagnosis. So echo is an experience which every one of experiences in our day-to-day life. If you shout into a well, the echo comes back at a moment later. This is exactly the physics of echo. This is exactly the physics of the ultrasound. You shout into a well, after some lag time, the sound comes back a moment later. The echo occurs because some of the sound waves shout in your voice, they reflect off a surface in a well. That surface will be water and travels back to your ears. This is exactly the principle that applies in the ultrasound. So generation of an ultrasound image. Echocardiography is a type of ultrasound test that uses high-pitched sound waves to produce an image of the heart. Those high-pitched ultrasound waves, those are supersonic, those are not audible to the human ear. Those waves are generated, and those waves help us in producing the image of the heart. So the sound waves are sent through a device called a transducer. You can see the transducer on your screen, and are reflected off various structures of the heart. We put the probe, which has a transducer in it, on the chest wall, left side of the chest, at various positions to get images of the heart, maybe to get images of the heart in various planes. Ultrasound waves are sent through these probes. They are reflected off from various structures of the heart, chest wall also. And those images, those ultrasound waves there, which are reflected back, they are reconstructed, and an image is formed on the screen and on the monitor. And for the general information, there is no special preparation for the test. Like patient does not does not necessarily have to be fast in a fasting state. It can be done anytime in the day, irrespective of the fasting status, and no special preparation for the test is needed. It's a routine. It can be a routine bedside, or it can be an emergency test. So this is the machine. There are various types of machines of echo available in the market. Philips, Sonosite, then GE, General Electricals. I've done a webinar with them, General Electrics, at Udaipur in 2017, where I was a faculty. So there are basically there are 5 components of an ultrasound scanner that are required for generation, display, and storage of an ultrasound image. Pulse generator applies high amplitude voltage to energize the crystals. So this pulse generator applies high voltage on the crystals. Those crystals are they stay in the transducer. Those are piezoelectric crystals of ceramic, titanium. So piezoelectric crystal is one. When an electromagnetic field is applied, it generates signal. That's the definition of a piezoelectric crystal. Then comes the transducer. It converts electrical energy into mechanical energy and vice versa. So this transducer is for both. It sends the signal as well as it receives the signal. Receiver detects and amplifies weak signals. Those signals that are scattered, which are attenuated, those are received back by the receiver, those peripheral signals. Display, then an image. Image is formed out of these electrical signals in variety of modes, in variety of planes, at different areas of the chest wall. And that is displayed on the monitor. And then memory, then this has a specific memory. Then an echo machine, an ultrasound machine for that purpose, has a specific memory to hold the images and cases. So application of the technique. There are basically, this one is M mode echocardiography. M is motion mode echocardiography, and second is 2D echocardiography. D is 2-dimensional echocardiography. There is 3D echocardiography also, and there is 4D echocardiography also. M mode is motion mode, which I'll explain you in detail. Although currently the role of M mode is limited, but there are certain scenarios where M mode is absolutely a first choice. So the main focus of our topic will be 2-dimensional echocardiography. There are 2 planes in which it is done. A simple photo, just a photograph. When we go to a photographer, we take a photo. That photo is a 2-dimensional figure. When we give it a third dimension, a depth, when we add the dimension of depth to a 2D echocardiogram, it becomes a 3D echocardiography. And moving 3D echocardiography is called echocardiography in a moving heart. I mean, not in a planar, not in a static position, but in a beating heart. When we are doing it on a beating heart, that's called a 4D echocardiography. And there are 2-3 varieties of 2D echocardiography, depending upon the situation where they are needed. Mostly, it is the transthoracic echocardiogram, in which we put the transducer, we put the probe on the chest wall. Second is transesophageal, where there are specific requirements for it. And for transesophageal echocardiography, there some it needs a fasting state of 8 to 10 hours. Patient should not have taken anticoagulants in the preceding 12 hours, 12 to 24 hours. and there's a special preparation for it. But it is also an example of 2D echocardiography, and then there is stress echocardiography. Stress echocardiography is mostly for those patients who have a hidden ischemic heart disease in which we want to reveal it. And transesophageal echocardiography is to see clearly the structures in the proximal part of the heart, like left atrium, left atrium, right atrium, and left atrial appendage, LAA, left atrial appendage. This is the best way to see clots in the left atrial appendage. So now the modalities of echo. A conventional echo, 2D echocardiogram, as we have discussed, 2D echocardiogram, it records the, it gives information about, it displays the motion of the heart in two planes, and then, audible now?
Yeah,
Clearly, then motion mode echocardiogram, which we will discuss. This is the conventional echo, and then Doppler echo. This Doppler is this is any Doppler for that matter is credited to the physicist Christian Doppler. So whenever you write Doppler in your practices also, he has to be capital. It should always be capital because it is the name of the physicist, the scientist. So Doppler echo, in which we practice the aid of Doppler, that comes in the form of, it can be either continuous wave Doppler, it can be pulse wave Doppler, or column flow Doppler. The gist of it is that all modalities follow the same principle of ultrasound. And all modalities follow the same principle of ultrasound, differ in how reflected sound waves are collected and analyzed. But the basic principle of ultrasound is followed same here. So what do we gain from an echo? As I told you earlier, that we don't have to view echo in isolation. It has to be, I'll be repeating this quite too often. It has to be correlated with the condition of the patient, the history of the patient, and we must know this, because this is only a corroborative investigation, and the final aim is to help in the diagnosis, arriving at a diagnosis. So what we see in an echo is, echo, we can simplify is ultrasound of the heart. Finished. Cardiac chambers, you can see the size of the cardiac chambers, whether they are normal or increased in size. The motion is at normal, or there are wall motion abnormalities, the functioning of the chambers. The thickness of the walls, like there are conditions, say hypertrophic cardiomyopathy, in which the thickness of the heart is excessively increased. Then if we talk about the chamber size, I have reported GLA, giant left atrium, which had a volume of 838 ml to be precise, and that is the largest size of the left atrium reported in Southeast Asia, and it found its mention in, you can see in Journal of Indian Academy of Echocardiography. We have reported that case, and that found its mention in Journal of Indian Academy of Echocardiography 2018. So that was the largest left atrium recorded. Then we can see abnormal structures like tumors, vegetations, masses, valvular structures like the calcification, if there is any calcification, if there is stenosis, if there is regurgitation. Then blood flow hemodynamics, if it is a laminar flow, it's a turbulent flow. Then other pathologies like pericardial effusion, cardiac tamponade, if there is cardiac tamponade, some prosthetic, for example, there are prosthetic valves, if they are functioning well, जैसे we do mitral valve replacement, aortic valve replacement, and we need to see them. We need to follow up those patients after every 6 to 8 months to see whether the prosthetic valves are functioning well or not. Then pacemaker wires you will see inside the hearts and any complications thereof. So the first requirement is the patient in some countries they take a consent from the patient before he or she undergoes echocardiography. But here in India, we take consent for dopamine stress echo, exercise stress echo, or transesophageal echo. For echocardiography, hardly any center takes a consent. So, but for your information, it's ideal to explain to the patient what exactly we are looking for, what exactly the patient is going through. And the position is left lateral position with the left arm tucked beneath the head. Left lateral position, and this arm should be beneath the head. So that the muscle on the left side of the chest that gets hitched up and it exposes the heart. And heart, in this position, the left lateral position, heart directly falls on the anterior chest wall, so that there is lesser distance between the transducer and the heart. That I will tell you why is that required, to get good resolution and get good penetrability. Then in the echo machine itself, you have to enter the patient's details, and most of the centers ignore this, but the super specialty centers like here in Max, Danta, Apollo, we always connect ECG to the patient, ECG to the machine, because some events in the cardiac cycle, they have to be timed according to the ECG. For example, if the patient is in atrial fibrillation, there comes the role of the ECG. Ideally, in every patient, ECG lead should be attached. Then there is a pointer you can see on this is the image of the transducer. There's this pointer. I'll tell you the importance of it, because when we go to the planes, when we go to the various waves of in the echocardiography, this pointer has a special importance, because direction of the pointer leads us to what exactly which plane we are looking for. Then this it's usually an LED. This pointer LED or in some lower end machines like Sonosite, they don't have a pointer. They just have a marking to help us in identifying this, identifying the side of the transducer which has a pointer. Then this transducer can be tilted up and down, angulated, side to side, and rotated, so as to give us various planes in the and various planes, like in apical 4-chamber view. When we break our wrist like this, this transducer is tilted upwards, it gives us a 5-chamber view. We'll definitely explain that. So this is an examination outline. These are the planes of visualization. This is the heart. Now, if we in long axis plane, we cut the heart longitudinally, right? We cut it longitudinally, and I'll show you the structures that are visible in the parasternal long axis view. In short axis view, this heart is cut across, side to side. In parasternal long axis view, it is longitudinally, and in short axis view, it is cut across. And in a 4-chamber view, apical 4-chamber view, the transducer position is at the apex, right here, right? Transthoracic echo. See here, this is the position of the patient, left lateral position, and this left arm under the head. So it gives maximal exposure, and the heart falls onto the anterior wall of the chest, which gives us clarity of the image formation. The image formation is quite good thereafter. The left arm is tucked under the head, and the right arm lies along the right side of the body. Standard positions on the chest wall are used for placement of the transducer. They're called the echo windows. Echo windows are these are echo windows. This is the apical, the left parasternal, this is suprasternal, and this is subcostal. There are other waves as well. On the right side of the chest, you get right parasternal waves. There are special indications for that. So normally, these are the waves that are required. Left parasternal, इसमें दोनों आते हैं, parasternal long axis wave and parasternal short axis wave. Then apical, this is the apical. Apical, why apical? Because we have to locate the apical impulse first. Apical impulse is the heart. Then we have to put our probe over there. Then this subcostal wave. Subcostal wave, it is the position of the probe is just below the xiphisternum. And this suprasternal wave in the suprasternal notch of the neck. So this is the standard position of the patient. Now, the echo windows. This is now we will discuss about the various positions of the transducer and the echo windows that are generated thereof. Parasternal long axis and short axis wave. For the plaques wave, the standard PTE, transthoracic echo, position is parasternal in second to fourth intercostal space with index marker directed towards the right shoulder. I told you the pointer on the transducer. This pointer should be pointing towards this right shoulder, right? Probe in hand, place it in second to fourth intercostal space wherever you get a good image, right? With pointer towards the left shoulder, right shoulder. That gives us parasternal long axis wave. So let's remember, parasternal long axis wave is in the left parasternal area, 2 to 4. Although it's not necessary. I'll tell you the situation where we might have to go lower down. But normally you get a good quality image in the second, fourth intercostal space. And here we have to remember that the pointer has to point towards the right shoulder. So we will gain parasternal long axis waves. And I told you earlier, long axis wave cuts the heart longitudinally, right? Okay. Patient is placed in left lateral decubitus position with upper body straightly. Upper heart in this position, as I told you, lies against the anterolateral chest wall and is less obscured by aerated lung fields, especially in full expiration. Then second to fourth intercostal space, left intercostal space. With marker towards right shoulder, it gives us parasternal long axis wave, right? I will tell you how the image looks like and what are the various structures that are seen in this wave. In some patients, like emphysematous patients, as I told you earlier, that it's not necessary to get that we'll be getting the image, all the images in second, fourth intercostal. In emphysematous patients, we might have to go lower down, right? And from this plane, we have to keep the transducer over there only. We have to rotate it in such a way that now the pointer is towards the left shoulder. We get the short axis wave. So parasternal long axis wave and parasternal short axis wave. Same position, left parasternal, second to fourth intercostal space. In parasternal long axis wave, the pointer is towards the right shoulder, and in parasternal short axis wave, it is towards the left shoulder. With this knowledge, we'll finish up with parasternal short and long axis wave. how to obtain the views. And now we'll see the apical four-chamber view, apical views. In apical view, this transducer is placed in fifth or sixth intercostal space in the midclavicular region. But I would rather suggest you to appreciate the point of maximal impulse first. Point of maximal impulse, cardiac impulse, right? We have to keep the transducer over there only. And with experience, when you're doing many echoes, then you get an idea yourself where to keep it. So the transducer position is the fifth or sixth intercostal space. The transducer plane in the apical impulse and aim towards the right shoulder blade. Here, and remember here, the pointer in the apical position, apical view points sideways. It points sideways to the left. To the left. If this is the transducer, and if I'm applying it like this on the fifth or sixth intercostal space, the pointer will be here. Pointer will be here, like this. I'm putting it here. The pointer will be here. 3 o'clock position. 3 o'clock position. And to obtain the apical window, first apical impulse should be palpated, which should be a norm for the beginners. It should be a norm. And when you are accustomed with the echocardiography, then you can go. Take the images without feeling for this. Now, the parasternal long axis view. What are the structures we see in parasternal long axis view? As I told you earlier, that in parasternal long axis view, we have to assume that we are cutting the heart longitudinally. So images of the heart will be the longitudinal images, not the cross-sectional images. In short axis view, we'll get cross-sectional images. So you'll have to remember this picture. This is what we get in parasternal long axis view. So parasternal long axis view, you remember second to fourth intercostal space on the left side with the marker dot or the pointer towards the right shoulder, right? So, and it is the parasternal long axis view which sets the stage for subsequent echo views like parasternal short axis view. And parasternal short axis view has, there are many. In parasternal short axis view, we see parasternal short is in the apical plane, in the papillary region, muscular plane, then at the base of the heart and at the mitral valve level. So we'll discuss that. So these are the structures which we see parasternal long axis view, and you have to remember it. This is LV, right? This is left atrium. This is left ventricle. This is left atrium. The wall between left atrium and left ventricle is mitral valve, right? This is RVOT. Remember, this is right ventricle. This is interventricular septum. This interventricular septum. And this is the aortic valve. So, aortic valve is on top of mitral valve. This is mitral valve, right? This is aortic valve. This is aorta. Here. Aorta. And this is left atrium. So these are the structures we see in parasternal long axis view. This is interventricular septum. This on the whole is left ventricle. This is aortic valve. This is aorta, ascending aorta, right? This is left atrium. This is mitral valve. These are the papillary muscles. These are chorditendinae, attachments to the mitral valve. This is left ventricle, and this is the posterior wall. This is posterior wall, right? And this is the apex of the left ventricle. So anteriorly, posteriorly, these are the structures which are seen in the parasternal long axis view. Anterior wall of RV, this RV, anterior wall of RV. Then RVOT, right ventricular outflow tract. RVOT is right ventricular outflow tract. Then there is interventricular septum. Then there is left ventricle, and then posterior wall of left ventricle, right? This is a structure anterior to posterior. This is left ventricular outflow tract. This is left atrium. Yahan pe you can see many times like this. This is a cross section of the descending aorta. And this, very important, is pericardium, the shinier part of this. In echoes, like this. This is pericardium, which gets more pronounced when there is pericardial effusion than this pericardium. Otherwise, it is barely seen unless there is fluid accumulation or there is excessive calcification of it. So we are done with the parasternal long axis view. Parasternal long axis view, this image has to be in your mind, and we have to think that in parasternal long axis, we are cutting the heart in a longitudinal plane. This is a parasternal long axis view. I'll show you an echocardiogram after we finish with this, the basics of it, and then there you have to tell me which I'll show you certain waves, I'll show you certain structures, and you'll have to answer me that time. Let's make it more interactive so that everybody benefits here. And I will definitely see how attentive you have been in the class. Then this is the parasternal short axis view. Remember, parasternal short axis view, same area where parasternal long axis is taken, but the pointer now is rotated and that faces the left shoulder. Right? And now at this point, we can tilt the transducer. We will get different views in the short axis. From short axis views are obtained at different levels from aorta to the LV apex. I'll tell you how. This is the view. This is short axis. I told you earlier that in this short axis view, we assume that we're cutting the heart cross-sectionally. And जैसे ही आपको गोला सा देखिए, this circular, this is short axis because heart has been cut cross-sectionally. This is short axis view at the level of the great vessels. Either we can say it at the base or at the great vessels, right? This is pulmonary artery. This is right outflow tract. This is tricuspid wall. This is right atrium. This is left atrium, and this is aortic wall. This is short axis view at the base, right? This. Now, parasternal short axis view at the mitral valve level. This is the mitral valve level. Here you can see this is anterior leaflet and this is the posterior leaflet of the mitral valve, a fish mouth appearance. This is parasternal short axis view at the mitral valve level. So we will see, for example, in cases of mitral stenosis, where we have to measure the area of mitral valve area of the mitral valve. This is the view taken, and this is indispensable in cases of mitral stenosis. This view is absolutely mandatory for calculation of the valve area. How is by slightly tilting angulating the transducer at the same position, second to fourth intercostal space with pointer pointing towards left shoulder. We are tilting it to get different waves from base to the apex. This is the mitral valve. This is short axis at the mitral valve area. Then at the level of papillary muscles, these are papillary muscles. Just these two. This is anterior papillary muscle and posterior papillary muscle. This is interventricular septum. This is right ventricle. So this is at the level of the pulmonary vessel, papillary muscle level. And this is very important. This is very important in cases of valve motion abnormalities. I'll show you a video where where in a case of left in an MI, anterior wall MI, there was a breach in the continuity of this interventricular septum. What do you call that? That's the drastic complication of this myocardial infarction. So उसमें interventricular rupture हुआ था. There was an interventricular rupture, muscle rupture. There was a leak from left, and that is one of the hardest things. And the mortality is around 80%. And this view is for detecting wall motion abnormalities in ischemic heart diseases, because there are various names given to the various segments, and from there we can get an idea which coronary vessel is likely involved, right? So our idea usually for the purpose of describing abnormal LV motion and LV wall thickness. Yes, LV wall thickness can also be we can get a fair about idea about the LV thickness in certain cases like hypertrophic cardiomyopathy, in which and amyloidosis, in which the wall thickness is increased. This is the short axis view at the peptide. This. Now the apical four chambers. We are done with parasternal views. Parasternal views are two types: left parasternal long axis view, second to fourth intercostal on the left side, which pointed towards the right shoulder, that's long axis, towards the left shoulder, that's short axis, right? Now the apical four chamber view. Apical four chamber view, we already discussed that the probe will be horizontal, the pointer will be at 3 o'clock position, and it will be in the 5th or 6th intercostal space, in the mostly in the mid-clavicular region, just beneath the point of maximal impulse, apical impulse. So transducer position, apex of the heart, marker dot position, as I told you, it's horizontal, and in it we can see, in apical four chamber view, we will see all the 4 chambers of the heart: left atrium, left ventricle, right atrium, right ventricle, mitral valve. We'll see tricuspid valve. We'll see interventricular septum. This is interventricular septum, right? And we can see interatrial septum. This is interatrial septum. See, for the sake of conventions, the left ventricle in echocardiography is shown on the right side. For conventions, we can change it on the echo mode where we have to, invert the image. We can do that, but for the sake of all images anywhere in the world, they show left ventricle on the right side. Now this is left ventricle, this is left atrium. The wall between them is mitral valve, right? That's understandable. This is right ventricle, this is right atrium. The wall between them is tricuspid valve. This structure between 2 ventricles is interventricular septum. This structure between 2 atria is interatrial septum, and this is the apex of the heart. Right? Okay. This is the apical four chamber view. This is the apical four chamber view. Now, at the same position where we have derived apical four chamber view, we will tilt. Now we will tilt the transducer anteriorly and rotating clockwise from apical four chamber to display LVOT. And what we say in our echocardiography parlance is four chamber view like this. We have made the four chamber view with the transducer in our hand, four chamber view. Now we break our wrist. थोड़ा सा ऐसे angulate कर लेते हैं. Just break our wrist and it becomes 5 chamber view. 5 chamber view means in which there is aorta in the picture. So apical 5 chamber view, see, right, left ventricle, left atrium, right ventricle, right atrium. The additional structure here, exposed here is the aorta, aortic valve and aorta, aortic valve. And this is 5-chamber view. Four-chamber view, apical 4-chamber view plus aorta, aortic valve or aorta is 5-chamber view. It places both the LV inflow and the LV outflow parallel to the ultrasound beam, permitting the Doppler estimate of both patterns simultaneously. It is best view to distinguish between subvalvular and valvular AS, aortic stenosis. See, this is 4-chamber. This is 4-chamber. Now, when we break our wrist, when we tilt like this, we'll get 5-chamber view, right? We'll get 5-chamber view. Now, the apical 2-chamber view, same position. See, in 4-chamber view, it is 5th or 6th intercostal space with pointer pointing horizontally towards 3 o'clock. Then we break our wrists, it makes it 5-chamber. Then in apical 2-chamber view, marker dot direction points towards the left side of the neck. We just sweep it like this, angulate it like this, 45 anti-clock from apical 4-chamber view. Then it gives us apical 2-chamber view. Only 2 chambers of left atrium and left ventricle are seen. This is a very good view. This is a very good view to see closely the left ventricle, left in wall motion abnormalities, in ischemic heart disease, in MIs. This is the view which gives us an idea about the involvement of the culprit vessel that is involved, apical 4-chamber, because it reveals to us both the anterior as well as the posterior surface of the left ventricle. This is anterior surface and this is the posterior surface of the left ventricle. This is apical 4-chamber. I'll show you. So why is this important? Because this will give us, because we have in segmental analysis of LV wall, we have to remember there are 2 classifications. One is 16 segment classification, and recently what is accepted widely is 17 segment classification. There are specific names of the various segments of the heart. Why they are important? Because we have to derive a wall motion score. We have to see the likability of the vessel involved. That this segment analysis we will exclusively and thoroughly study it in our next topic, in which we will exclusively study the left ventricular function. Now we are done with parasternal view. We are done with apical view. Parasternal log axis and short axis. Apical 4-chamber, apical 5-chamber. 4-chamber and 5-chamber is the difference here. That in 5-chamber we see aortic valve and aorta, and then apical 2-chamber view is also there. Then there is also another view, what you call apical 3-chamber view. I'll show you that in a video. Now, after completing the apical views, we'll go to the subcostal view. So in subcostal view, the transducer is placed just below the xiphisternum, in the xiphoid and the left subcostal area, and the beam is aimed towards the left shoulder, again towards the left shoulder. And in subcostal view, the patient lies spine. In other views, the patient lies in the left decubitus position, left lateral position, with left arm tucked behind the head. So these are various views we can generate in subcostal plane. Mostly subcostal view is for in the pediatric population. It's very important for the atrial septal defect. And in adult population, it is mostly for the inferior vena cava. Comments on inferior vena cava to obtain a good view of the inferior vena cava, because this the size of the inferior vena cava and its collapsibility with inspiration gives us an idea about the right atrial pressure. So in adult cardiology, the echocardiography, the subcostal image is for inferior vena cava size and its collapsibility. This is inferior vena cava, and inferior vena cava opens in right atrium. So this is inferior vena cava. This is the subcostal view. Another view is suprasternal view, in which the transducer is placed in the suprasternal notch here. Suprasternal notch right here. Base of the neck. For the suprasternal window, the transducer is placed in the suprasternal notch or just above the left sternal border. The beam should be directed to the lumbar vertebrae. Pointer should be directed upwards or slightly angulated to the left, right? Slightly angulated to the left. Patient is lying spine with extended neck. Yes, neck has to be extended like this. So spine position in suprasternal position for suprasternal views and subcostal views. So what are the structures we see in suprasternal view? This suprasternal view many times is this reveals such hidden entities like coarctation of aorta. This is the only way where we can see coarctation of aorta. So the structures which are seen in suprasternal view, this is here, it is an ascending aorta, this is the arch of the aorta, and now it descends, right? So aorta in this entirety we can see here. Ascending aorta, arch of aorta, it is branched. Descending aorta, pulmonary artery here, and patent ductus arteriosus. Although for patent ductus arteriosus, the best is the ductal view in short axis view. This is suprasternal view. So this was about 2D echocardiography, right? Now about M mode echocardiography. M mode is motion mode. M is motion. This used to be of great importance in the yesteryears, where now with the advent of 3D echocardiography and with the advent of transesophageal echocardiography, this is not given that much of an importance, but there are certain conditions where this is absolutely the role of M mode is absolutely irrefutable. It is because this is one mode which has the highest temporal resolution. This M mode, the highest temporal resolution in any kind of mode in echocardiography is of M mode. So M mode is not a picture of the heart, but rather a diagram that shows how the position of its structures changes during the course of the cardiac cycle. We'll tell you how it is taken, where the cursor should be, and what it depicts. M mode recordings permit measurements of cardiac dimensions and motion patterns. Most important is the motion patterns of it. This is like we have a CCTV camera somewhere on a road. So CCTV camera will show us the number of vehicles, the number of people crossing the plane of that CCTV, crossing the plane of that CCTV in a particular point of time. So if we want to see the images of people who are crossing the particular CCTV camera at 2 p.m. So it will give us the information of movement about those people at 2 p.m. only. 2:10 wali picture us time mein nahi dikhai 2 p.m. only. Exactly is the case of this. So whatever is in the range of it, that CCTV camera at a particular point of time, it will give us good details about that only. At a particular point of time. This I'm stressing upon this particular point of time, because this is one modality which has the highest temporal resolution. Even this is one of the earliest modalities of echocardiography, but still in the present scenarios, this is used for temporal resolution. No better investigation, no better modality of echocardiography with temporal resolution than this MO. So permits measurement of cardiac dimensions and motion patterns, also facilitates analysis of time relation with other physiological variables such as ECG and heart sounds. Heart sounds, phonocardiogram, some labs also, while attaching the ECG lead, they also attach that phonocardiogram with the heart sounds. So to create an mode image, ultrasound is transmitted and received along one scan line only. I'll tell you how. This is obtained by applying a cursor line to the 2D image and aligning it perpendicularly to the structure being studied, right? The transducer is angulated till the cursor line is exactly perpendicular to the image. See, like this. This is parasternal long axis view. Now, if we want to see the, if we want to apply M mode to it, see, this is the transducer, we can apply M mode here, 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 to whatever structure we want to see. But the only requirement is that it has to be perpendicular to it, as much perpendicular as possible to it, to get various planes of various views of possible M mode. Like the cursor can be placed here to get information about the apex, about the hair, about the mid LV, about here. If we put it here, we'll get the information about the motion of mitral wall. If we put it here, we'll get information about the motion of aortic wall. So this is parasternal short axis view at the mitral area. And when M mode is applied to it, it can give us an idea about the movement of mitral wall with respect to time in the cardiac cycle. Those various movements recorded are these. Although nowadays, see, these in the previous years, say in 90s, this M mode was used, this EF slope was used as a marker for mitral stenosis, right? So what we used to say is that flattening of EF slope indicates the severity of mitral stenosis. So if it is more flat, the severity of the mitral stenosis is more. But with the advent of other parameters like volumetrics, like 3D echocardiography, this is hardly ever used now. But we can still remember that flattening of the EF slope in mitral stenosis gives an idea about the severity of the mitral stenosis. So what exactly I was trying to tell you is that if we apply M mode to this plane, to this short axis view at the mitral level, and we can record movements of various movements of the mitral valve with respect to the cardiac cycle. Similarly, the movements of aortic valve can be recorded if M mode is applied to the aortic valve. And the most important value of echocardiogram in present case scenarios is in giving us an idea about the chamber quantification, like thickness of the interventricular septum, posterior wall, and it gives an idea, although this is Tico's method. Although this is hardly used nowadays for the EF calculation, but it gives us an idea about the chamber size of the LV. And if we do multiple measurements of the interventricular septum, the cavity size, posterior wall, then interventricular septum in systole, posterior wall of the LV in systole, then we will get an idea about the left ventricular ejection fraction. But still, this is one of the most important methods which we use currently for measuring the chamber size of LV and the thickness of interventricular septum and posterior wall. For chamber quantification, this is used for M mode is currently used for chamber quantification, one, and most important, where we are stuck, this is the parameter which has the best temporal resolution. Measurements I'll definitely show you in the subsequent in chamber quantifications. I wanted to actually show you something. I wanted to share a normal echo with you with the images and videos, and I want actually you to tell me which view is this, so that I get to know how much you have grasped. And I will definitely ask you the chambers we see, the structures we see. But like this.
Parasternal long axis view.
So this is parasternal long axis view, right?
Parasternal long axis view.
Okay. And what do we do in parasternal long axis view? What is the probe position, and where does the pointer point?
Pointed toward the right shoulder.
Very good. And probe position?
Probe position is vertical.
No. Where do we place it?
So in the second to fourth intercostal.
Second to fourth left parasternal region, right? Intercostal space with pointer towards the left shoulder. So this is parasternal long axis view. So this is, can you see my pointer there? What is this?
Yes, sir.
This is
Right ventricle.
Very good. This is
Interventricular septum.
very good. This is
Left ventricle.
this is
Left atrium. Mitral wall. Right
Aortic wall.
Aorta.
this is
Posterior wall.
very good. And this shinier part, this is
Capillary muscle.
pericardium. These are why one. Now I'll show you another video, right? This is
Short axis.
short
Short
तो है, गोला बना हुआ है, short axis तो है ये. Where?
Capillary level.
Very good. This is what? Which one is this?
Capillary muscles.
Anterior, this is anterior papillary muscle, and this is posterior papillary muscle, right? Got it?
Yes, sir.
Or we can say that this is short axis at the mid level. ये भी कह सकते हैं, short axis at the mid level, है?
Okay.
This echo has been done by me. So this is. So I'm glad, yeah, you people have remembered. This is short axis view at the base.
Aortic.
Yes, at the base or great vessel level, right? This is aortic wall. This is pulmonary wall here. This is right ventricle. This is the tricuspid wall. This is right atrium, and here यहाँ पे left atrium होता है. Good. दो चीजें. No. I'll show what this is.
Four chamber.
Four chamber.
Apical.
Apical four chamber.
See, there can be a four chamber in the subcostal view as well. So the correct name is apical four chamber view, right? Apical 4-chamber view. This is
Apical 2-chamber view.
Chamber view.
This is anterior wall of the LV, and this is inferior wall of the LV, right?
Anterior, inferior.
ठीक है? If there is an inferior wall MI, only this ये वाला segment है, this will be gone. In anterior wall MI, this segment will be gone, right? There will be no movement or lesser movement. Okay. Then एक व्यू मैंने बताया था आपको, which I did show you there. मैंने बोला था apical 3-chamber view होता है, ठीक है? This is apical 3-chamber view, in which this is more or less like the apical, like the parasternal long axis view. अगर आप कि अगर parasternal long axis view लटका दें, तो ये बन जाता है, ठीक है? Exactly at we have to place this probe at the 5th or 6th intercostal space apical view में, ठीक है? फिर उसको घुमा के towards the left side, you'll get this view. This is not that important, but this is also one view, the apical 3-chamber view, in which we see left atrium, left ventricle, and this is aorta. ठीक है? तो ये मैंने बताया था आपको, ये दिखाऊंगा. And one view I want to show you is this. ये कौन सा view है? Let's forget about the color part. Which view was this?
5-chamber.
Very good. 5-chamber.
Apical 5-chamber aortic wall.
Yes, and this color Doppler is at the apical at the aorta.
Aorta.
यहाँ पे we are trying to see the flow in of the aortic, the blood. It will be. I just wanted to make it interactive. I just wanted to see how have you remembered a bit or not, because I want to ask you, are you reading any book or what?
No, some YouTube videos, sir, for the practice.
See, I think you should get a good grasp. Easy book, which I'll tell man to share with you. Okay, so I would request you people to go through that. It'll hardly be 50 pages. So
Sultan told us he will provide us with some book.
Okay. Then she
till now he is not given anything.
Then she will surely provide.
Sir, we need the book. Actually, we don't have any knowledge regarding the. I don't have any knowledge regarding the book. What to read for the.
I'll ask her, ma'am, once we are done with the class.
Sir, one more thing, sir. I joined late because I need a video also.
Video?
Yeah, this recording video, sir.
Okay, but I haven't recorded it yet.
Okay.
I haven't recorded it myself. So one of them is yes, that. Okay. We'll unmute it again and we'll. You have been very patient with the introduction part. Now the part we are going to learn is the physics part of it. And as everybody will agree with me that physics part is very dry for the beginners. We will not go into the details and the fine details of it. I will try to make it very palatable to you. I'll try to make it a bit easier for you people, so that you don't get caught in the complexities of the physics part, because that's not what we require. We don't want to create any doubts. We are here to simplify the things, and I will definitely try my best to present a simplified version in front of you people, right? So now we have to learn a bit of physics, because this is some parts of it I will stress more, which are of importance to us. See, the physics part is for us experts, for the beginners and those who want to have a basic understanding of it. They need to learn few things out of this what I'm presenting in front of you. So the ultrasound waves are supersonic waves, right? Our human capacity, the hair can hear frequencies. Our human ear can hear frequencies between 20 hertz to 20,000 hertz. Higher than this range, that's termed ultrasound. And sound waves are, and in the diagnosis, the frequency what we use in ultrasound and in echo purposes for that matter, that is somewhere around 1 to 20 megahertz, which is way beyond the capacity of a human ear to hear, right? To comprehend. So we need to know a bit about the sound waves, that is pure physics, the frequency, right? A diagnostic medical ultrasound is the frequencies that we utilize are somewhere around 1 to 20 megahertz. Velocity of propagation, the velocity of the sound that's 1540 meters per second. Wavelength is the distance between two waves, either troughs or the positive side of on the upper side of the horizontal or the lower side of the horizontal. Between two successive waves, the distance between two successive waves is amplitude. Is the wavelength. So the amplitude is in decibels. Amplitude means noise level, right? So it is in decibels. This is the propagation of the sound wave, ultrasound per second. Okay? This is the wavelength between two positives or between two troughs. Okay? And this is the propagation velocity. And these are the number of cycles per second. I know this is a bit dry, but I will try to simplify a few things to you. I will not share the entire this entire the PPT with you, but I'll try to share a few important things which will be of help to us. So this PPT will cover our the physics part and the knowledge part. Now, piezoelectric crystal, what I was talking about, those are made of quartz or titanate, ceramic, right? So piezoelectric crystal is one. When placed in an electromagnetic field, it generates a signal, right? So what exactly happens? I actually want to show you. Just palatable. Transmission frequency, the central frequency emitted by transducer, right? Then the bandwidth is the range of frequency of the ultrasound pulse. Wider band width allows improved axial resolution. And time delay between transmission and return of signal. What exactly happens in ultrasound, in this echocardiography ultrasound, is once we put the transducer on the chest, a burst of signals goes inside, the ultrasound goes inside. It strikes various structures on its way, like the chest wall, then the heart, then the blood inside, then the posterior wall of the heart, maybe lungs sometimes. Every structure that comes across its way, it strikes that. And then it gets reflected back. Some waves get reflected, some get refracted, some get attenuated, right? So that's what happens to the ultrasound waves that are ultrasound waves that are emitted. Either they are reflected, means reflected waves get back to the transducer. They are refracted or dispersed. Some are attenuated and some don't return back. So that is the ultrasound and tissue interaction. So the basic principle is that a pulse is a set of frequencies that goes inside through the transducer. It goes, strikes the chest wall, meets various organs, systems on its way, and reflected waves are received back. Those are amplified and an image is formed on the basis of the received signals, right? So the loss of ultrasound as it propagates through a medium is referred to as attenuation. It is the rate at which intensity of ultrasound beam diminishes as it penetrates the tissue. For example, there are different tissue and ultrasound interactions. Like the ultrasound beam that is emitted strikes the bone as well. The signal will be different than that reflected by the pericardium, then that reflected by the myocardium, then that reflected by the RBCs, then that reflected by the walls. Maybe if there are prosthetic walls, the signal will be different. So different signals are received in a different way, and an image formation is formed, and an image is formed depending upon the different signals that are received. So the attenuation has three components: absorption, scattering, and reflection. So what exactly I want you to remember is that the principle of it, that ultrasound beams are emitted, they go downstream, some are reflected back, some are not reflected back, some are scattered, attenuated, or not reflected back at all. And different structures underneath reflected in a different way. That is the property of it. Bone will reflect it in a certain way. Muscle, pericardium, blood, if there is a pericardial effusion, that will reflect it in a different way. And an image is formed accordingly. The most important thing in ultrasound or in echocardiography or even in CT and MRI is the resolution. Resolution is the ability to distinguish two objects in close proximity. Two close objects placed in close proximity, the ability of an ultrasound, the ability of an echocardiogram to distinguish them as two different entities. That is what the resolution is all about. The clarity, let's say, for example, if you're traveling in an aeroplane, when we look down, we see those buildings, they are clumped together. From a height, when we look down from an aircraft, the buildings look clumped together. But as we go down towards the buildings, we can see they are different. So our resolution, when we are high in the air, our resolution is less than when we are close to the buildings. So that's what you call resolution, to identify two objects in close proximity as different things. Spatial resolution and temporal resolution. Spatial means in space and temporal means in time, with respect to time. Spatial resolution, it is defined as smallest distance that two targets can be separated for the system to distinguish between them. So spatial resolution is the ability of a system, and it is defined as smallest distance that two targets can be separated. So it is, in fact, spatial resolution is actually the property of a system to identify two targets as different, as separated by a distance, by a certain distance. So it has got two components, axial and lateral resolution. I'll try to explain it with some pictures to you. What we actually want from you, and what we want you to understand about the resolution. So simple mota resolution is the ability of a system and ability of our echo to distinguish two objects in close proximity. Okay. Now there is spatial resolution and there is temporal resolution. Spatial resolution, it can be in the axial, in one axis, or in the lateral resolution. And I'll tell you in the with the images how these two what actually we infer from it. Lateral resolution is to distinguish two reflectors that lie side by side, and axial resolution is two structures that are lying along one line. Along one line, जैसे parasternal long axis में RVOT, interventricular septum, LV, and posterior wall, they are in one line, right? So that is the axial resolution. Then, that is axial resolution. Then now lateral resolution. Lateral resolution, we can say in apical four-chamber view, mitral valve and tricuspid valve, different sideways. How two structures that are placed sideways are viewed as different. That is lateral resolution. So for lateral resolution is the structures, the structure or reflectors that are placed side by side. This is lateral resolution. And axial resolution is those that lie in single plane, single axis. Temporal resolution, this is the most important. Frame rate is called temporal resolution. And this is because temporal resolution, this is very, very important because heart, that's a beating organ. And every event of the heart or structures of the heart, for example, mitral valve. Mitral valve ki opening, closure, semi-opening, mid-diastole, mid-systole, that has to be timed with the cardiac cycle. Ki end systole mein kya ho raha hai, end diastole mein kya ho raha hai, mid-diastole mein kya ho raha hai. So that's what we call temporal resolution. Ability of a system to accurately track moving targets over time. That is temporal resolution. And it depends on the speed of the ultrasound. Speed of the ultrasound, you cannot change. That's fixed, 1540. And depth of the image. For example, when we are placing the chest, the probe on the chest, right? The structures that are closer to the probe, like in apical four-chamber view or in parasternal, those structures that are closer to the heart, to the transducer, they'll be seen neatly and cleanly and clearly. Like in apical four-chamber view, the apex is towards the probe, towards the transducer, is in front of the transducer, so it lies closer to it. So the apex and the ventricles, they'll be seen very clearly. Then the atria, because they lie in the far field, right? This is the reason in 2D echocardiography, the left atrium and left atrium and right atrium, those structures that are far from the apical waves, they are not seen that clearly as the ventricles. And in transesophageal transesophageal echocardiography, when we put the probe through the esophagus is the structure which lies very, very close to the right atrium and left atrium. Those two structures are seen very, very clearly in transesophageal echo. So the frame rate to me, what we try to achieve is a frame rate of 30 to 40. If it is more, that's better. but at least we shouldn't compromise on a frame rate less than 30. These are the knobs. This is your machine. See, knobs are like the various, for example, if you are buying a car, when you buy a car, you want to know exactly where the clutch is, brake, accelerator, gear, other innovations, modern innovations. So those are the things that guide us for the smooth running, smooth functioning of the car. Same is the way we need to be abreast with the various knobs of this ultrasound or echocardiogram, so as to know which knob is where, and we should know a little bit about the knobs, what are their functions, and how do they help us, because ultimately our aim is to get a good quality picture. I'll tell you with examples about this M mode, what it does, and the pulse repetition frequency, and frame rate. Frame rate is temporal. Just remember, frame rate is temporal resolution. So these are various knobs on in the echocardiography machine. Gain is the amplitude or the degree of amplification of the received signal. You might have, I don't know whether you people have any idea or not. When in the 10, 20, 30, 20 years back, when we used to switch on a radio, and many times we used to hear two stations at a particular point of time. One was louder and the other was less louder. And when we increase the volume, तो दोनों का volume बढ़ जाता था. Same is the case with the gain. So when we increase the gain, those signals that are weaker, that are also amplified. So gain increases, it amplifies the degree of the received signal. Gain, right? I'll tell you how. This is normal echo. This is the normal terrestrial non-exclusive, right? When we increase the gain, see how bright it has become. How bright it has become. In black and white TVs also, when we increase the gain, the overall picture becomes brighter. So let's remember, gain is brightness. When we increase the gain, the overall brightness increases. So gain should be around 50. It should be around 50, as is the compression. So actually, if you don't understand these things, the physics of it, I'll tell you what to remember. At least a frame rate of around 30 to 40, I told you. Gain around 50. Another one is compression, around 50. Don't bother about this the physics part of it. That is very complex. If you want me to continue with that, I can continue with that. I have another PPT that's around 70 pages, 20 slides about that, but I don't think that will be palatable to you. And gain on the left hand side has been increased, and see gain, how bright the picture is. It is 79 here. See, 79 is also not good. It should be around 50. Here it is 92% gain. Compression is 15, and compression here is 50. Right? So there is another one, time gain compensation. Time gain compensation is this, TGC. Time gain compensation. And this is TGC, time gain compensation. Time gain compensation is TGC, right? TGC and LGC. Time gain compensation is, if you want to make this part, these are the buttons of time gain compensation, right? If you want to make this part brighter, you can slide these to the right? You can slide these to right. Any part of it, of the picture, from side to side. If you want to make it brighter, you can move that particular. You can move these particular these semi-knobs to the right. These TGC, these controls. You can whichever structure you want to make brighter, sweep it to right. If you want to make the middle part of the picture bright, sweep the middle part to the right. If you want this part to be brighter, sweep the lower end to the right, so that the picture becomes presentable, and the far fields like these fields, they become appreciable. Lateral gain compensation is, see, that was like this picture. It is like this, right? You can make one half. If you want to concentrate on the right, see, like here. If you want to concentrate here, make it up. Take these controls up, so that only this portion of the heart gets the gain in this part of the in this half is increased. And in the machines which we purchase now, in the last 4 or 5 years, we don't have to worry about the gain, the control, because there's a button there, eye scan, auto scan. Like here, I'll show you. This eye scan, this. You have to press on this button. The machine will automatically select appropriate gain and appropriate compression, appropriate zooming, and appropriate depth. It will itself select the appropriate parameters. You don't have to worry about that. But just remember, compression gain should be around 50. This TGC and LGC. TGC is for the this horizontal sweep, and LGC is for the vertical sweep. Whichever area you want to make brighter, whichever area you want to focus on. I know it is a bit definitely dry. See, this is the picture. When you put this apical 4-chamber view, you have made this view without fiddling with any of the knobs. Now, when you press eye scan, this button, automatically it selects. See, the gain is 55, compression is 52. Here gain is 90%. So automatic scan, or this auto gain or eye scan, it automatically selects the appropriate parameters for the image. This is widely available in newer machines. You don't have to worry about that. Depth. Display depth affects the pulse repetition frequency and frame rate of the image, allows maximum display of the, see, there is a, this is the button of the depth. I mean, whatever depth you want to keep depends upon your area of interest. Suppose we are having apical four-chamber view in front of us. Now we want to focus on the mitral valve. So we'll increase the depth so that we focus on the mitral valve only. Similarly, we can customize our picture according to our area of interest. Yeah. And this is compression. I told you the compression should be around, should be in the 50s as well. Same. The golden rule, remember, is gain and depth go side by side. They should be equal or almost equal. And in the present day machines, this technical difficulty is not there. We have to press I scan it and get the image quality of your liking. Dynamic range or compression. I told you the reflected signal, the reflected signal, it gets reflected from the bone, from the pericardium, from the blood. So there are some signals which are immediately reflected back. Some take time, and this dynamic or compression, this is the reflected signal is greater than when the amplitude range of the reflected signal is greater than the display capacity of the ultrasound system, so that those signals, see, signals coming from the far field, from the near field, from the bone, from the muscle, from the valve, from the blood, they are different. And they are compressed into a certain band. This whole gamut of varied frequencies, those are compressed into a single band from white to black on a gray scale. That's what you call dynamic range or compression. So compression is ability of the machine, ability of the ultrasound to compress differing frequencies. As a result of why there are different frequencies, because that is as a result of different natures of the structures that this ultrasound beam falls on. So it is the ability of the machine to compress them into a range of values. See, this is dynamic range I scale or compression, in which I wanted to show you something different. This is the focus. Whenever we are taking an image, we need to know the focus of our interest. If we are taking a 4-chamber view, if we want to focus on the mitral valve, this focus should be on the mitral valve itself, not towards the apex, not towards the base. See, this compression here is 50. This is an acceptable image. Compression here is 37. It has become darker. So we have reduced the compression. It has become darker because some frequencies are not included there. Sector width means the area of interest, what we want to see. See, this is a big sector, this is a smaller sector, right? Now, when we are concentrating on this short axis wave, we don't require this much, we don't require it this much, we just want only this to be the area of our interest. Why this is important? For just see the focus. Focus is very good. It is appropriately placed. Now, when we decrease the sector width, what we do is that the part of interest, we are only concentrating on the part of interest. See, यहाँ पे भी हमें इतना ही देखना है, यहाँ पे भी हमें इसी पे concentrate करना है, ठीक है? वो जो ये unwanted frequencies है, इस जगह की, we don't want that in our picture. Now you can see the frame rate here. It is 51. Good. This is good. But here, when we have decreased the sector width, the frame rate is 80. So 80 is more than good. This is extraordinary. जितना ज़्यादा frame rate होगा हमारा, उतना we are comfortable with the picture, right? So frame rate directly increase our picture quality. And when we know that we are interested in this area only, why should we be bothered about this? Why should this be in our sector? So we need to lower down our sector. To get a good quality image, we need to concentrate on that part only. We have to, our area of focus should be, I mean, we should know about our area of focus. Focus, I told you this line where it should be and where it should be. Because we are concentrated on this. Agar ye yahan hoga, to kya fayda hai? Like this. Exactly like this. If you're concentrating on this, right? Short axis. Focus yahan hai. So the image quality is not that good. Now we haven't done anything extra in it. We have just brought down the focus to this at the area of interest. देखो यहाँ frame rate 47 है, यहाँ पे frame rate 47 है, depth 17 है. बाकी सारे parameters almost same है. But बस just bringing the focus at the area of interest, we are improving our image quality. Why this is important? Why this image is better than this? See, we can see endocardial definition here. We can see it clearly, which is hazy over here. So zoom. If we want to see vegetation on mitral wall, if we want to see any pathology of the mitral wall, why should we be concerned about this part? So we'll zoom this area, right? Here's a button of zoom button as well. This is zoom button. Zoom is, we are enlarging the area of interest. But depth, if you are increasing the depth, we are, magnifying the picture. In zoom, we are magnifying only the area of interest. That's the difference between zoom and depth. Zoom. See, what I want you to remember is compression and gain should be, almost same, around 50. Sector width should be lesser so as to accommodate only the area of interest. Frame rate should be as high as possible. See, there's not a separate button for frame rate. Frame rate increases when we decrease the sector width and when we decrease the depth. Frame rate increases, right? So at least a frame rate between 30 to 40 or more than 40. Jitna zyada frame rate, that is acceptable to us, but at least it shouldn't be less than 30. So, and focus, we will always keep the focus, this part at our area of interest so that our image is clean. And zooming in some circumstances, when we want to zoom at a particular area, particular wall, be it particular segment, then we zoom that. Then we zoom that segment so as to get a good view about that. So the final comment for good quality image: skilled use of echo machine and transducer, right? Effective patient positioning, which is very important. Left lateral side with arm behind the head. Breathe in. See, breathe in and breathe out. You have to ask these maneuvers are important in patients, and different structures become, see, when the patient exhales, the heart falls on the anterolateral part of the chest. but there are some structures which we want to see in inspiration. Like in emphysematous patients, we may not see the, we may not reach to the apex of the heart. So in them, we ask the patients to inhale and hold the breath for as long as they can. That's the only way we'll get to the apex of the left ventricle in emphysematous patients. So breathing exercises, I mean, breathing, we may ask the patient to breathe in or breathe out, depending upon what we want to see, right? Constantly readjusting the ultrasound machine settings in order to assure the best resolution for the conditions encountered, right? Proper gain setting, somewhere around 50. Minimum desired depth, that which I was telling you, depth and sector width. Depth and sector width, jitna zyada hoga, that will compromise our image quality. So there should be minimum. Proper dynamic range. Dynamic range is compression, that I was telling you. 50. Optimum use of focus and zoom. Use of tissue harmonic imaging, THI. That this used to be a feature of sonocyte and earlier ultrasound machines. This is no longer a feature in our machines now, because jo nai machine hai, those new modalities, they have a very, very good resolution. They have a very good resolution. And last but not the least, having a compassionate and caring concern towards the patient. We don't have to, I mean, apply it too hard, and we have to be gentle, and constantly we have to remind ourselves that we are taking these images of a live patient, right? So we have to be compassionate and caring and concerned towards this patient and the quality of the imaging provided. So I didn't teach you this in entirety, this these slides, because I don't want you to get confused. But one thing I will definitely share with you is the M mode. Can you see it? Can you see this? So this is an M mode which has been placed across this aorta and left atrium, right? So another M mode this is what I wanted to share with you. This is the M mode across, this is parasternal long axis wave, right? Across the middle of left ventricle, I have cut this, I have taken this across the left ventricle, right? Okay, let's have a look at the image first. This is parasternal long axis wave. See, 45 hertz, good frame rate. Now this is through the middle of it, right? It is cutting across the middle of it. See, this is the ECG which is attached, right? End of T wave on ECG is end diastole, and this R wave, the top of the R wave is end diastole. So end systole is T wave, end of T wave, and this is end diastole, right? So now we can time the events. Now we can time the events of this of the structures that come in the range of the M mode. We can time these events according to with respect to the cardiac cycle, right? So this is why M mode has got the best temporal resolution. You can see this is septum, this is motion of the septum, right? This is posterior wall, this is motion of the posterior wall. These are, see, yahan pe jo, these are chordae. This is the movement of the chordae, these chordae of the mitral wall. Okay? These are the chordae of the mitral wall. This is free wall of the right ventricle, right? Now, if we want to see what is happening in the left ventricular posterior wall during end systole, we can see it here. If we want to see what is happening to the interventricular septum and posterior wall during end diastole, we can easily time it to end diastole. We can easily time any event of any mechanical event with the electrical event here. And this is possible through the M mode only. So what I want you to understand is that we can effectively time the events, mechanical events in a cardiac cycle with the electrical event. Electrical event तो ये हो गया ना ECG. Mechanical events with electrical events, and this is possible only because of M mode. Now M mode tells us, see the what is the duration of a cardiac cycle? 0.8 seconds. ठीक है. Systole is 0.27 seconds and diastole is 0.53 seconds, right? इतने छोटे से cardiac cycle में M mode helps us, and M mode delineates for us what is happening to the interventricular septum during systole, during diastole, during systole, during end diastole. This is too much of an information provided by M mode during cardiac cycle with respect to the structures that are placed across it. So M mode, मैंने आपको बताया, whatever structure whatever structure is cutting through the M mode, it will tell us the motion of that very particular structure with respect to the cardiac cycle. And that's why despite so many advances in echocardiography, advent of 3D echocardiography, 4D echocardiography, we still say, and we still consider it, this M mode, as the gold standard for temporal resolution. Because time events, the events can be timed according to the cardiac cycle, and there's no other better. Even 3D has a lesser temporal resolution than M mode. So this is one thing what I wanted to share with you, the M mode. And from here we can make measurements. As I told in the basics also, we can make measurements of, see, now if you want to make the measurement of this intervertebral septum, यहाँ से यहाँ measure करेंगे, and we can say that intervertebral septum measures this much in end diastole. Systole में देख लेंगे कितना measure करता है systole में. Same way we can say this is intervertebral septum, this is posterior wall, and the space in between is left ventricular cavity. Now we can easily calculate the diameter of the left ventricle during diastole, during systole, during mid diastole, and this is possible only because of the M mode. 2D में भी कर सकते हैं, but this is the best way to quantify the chambers. This is the best way to quantify the chambers. I think we have had enough for today. I think we have had enough for today. I know the physics part we can understand is always a bit tricky in the sense that it is many a times boring and dry, but I've tried my best to share only the information that you will gallop and that is palatable to you, and try to simplify the things by telling you the gain settings, compression settings, and all that stuff. So let's call it a day then, and these people will inform you about our next date. So, and the topics will also be given to you, the topics that I'm going to teach in the next class. Thank you for bearing with me. I know it was a mixed class. Introduction part was good. The physics part, I couldn't help much. I tried to simplify it as much as I could do, and in the subsequent classes, definitely we'll be sharing more information, and let's make it more interactive. Thank you.
A brief introduction of himself.